Thank you so much for inviting me at this talk. I'm looking forward to presenting these two presentations with some interesting cases. So the first presentation is going to be on abnormalities of the GBMs. And I do have two cases I want to present. So the first case was a case that I had in a previous institution several years ago. It was a 40-year-old man who had a history of hearing loss, corneal transplant, and he also had progressive renal dysfunction and nephrotic range proteinuria. And talking with a nephrologist, it sounds like this patient had some proteinuria even in high school. And he did also have hearing loss, and he also has two brothers who have kidney issues who are on dialysis. So it seems like there's a family history of kidney disease. Genetics wasn't done at this point. So they did a biopsy, and they did show on the biopsy very normal looking glomeruli on lower power, but on higher power you can see that there are these thick GBMs. They kind of look like they're corrugated. They're a little bit frayed at the edges. There's no hypercellularity. The capillary lumina are patent. There's no increase in mesangial matrix or cellularity. And then on some of the glomeruli, there were some FSGS lesions or focal segmental glomerulosclerosis. So you can see this is an H&E stain, and there is matrix accumulation, and there's like an adhesion of the tuft in a perihilar area. And then on electron microscopy, you did show quite a bit of GBM or a glomerular basement membrane abnormality. So you can see there's these sub-epithelial scalloping, there's some outpouching, and even the lamina density, you can see that there are these lamellations or splitting of the GBMs. And so looking at the immunofluorescence, there was no staining for immunoglobulin or complement as expected because there's nothing proliferative in here, and there were no immune deposits on the EM. Type 4 collagen was done, and it did show, so here is a collagen 4, alpha 5, and 2 stain. So the green is supposed to stain alpha 5, and then alpha 2, which is stains all basement membranes, is red. So usually if you see normal staining in glomerular basement membranes and distal tubules for alpha 5, it should look green. And when it merges with the alpha 2, it should look yellow. So you can see it looks completely red. So there's no staining for the alpha 5 type 4 collagen in the basement membrane. So he's missing alpha 5. So based on this, it looks like he has an FSGS with glomerular basement membrane abnormalities that are related to a hereditary nephritis. And he has clinical features of what looks like an Alport syndrome. So just to talk a little bit about the disease, Alport syndrome was first described in 1927 in a family with hereditary nephritis. They did have proteinuria, hematuria, and sensory neural deafness in the male members of the family. It's considered a defect in type 4 collagen of basement membranes, and it's rare. So type 4 collagen, there's 6 alpha chains in type 4 collagen, and alpha 1 and 2 is typically ubiquitous. You can see pretty much essentially in all basement membranes. Alpha 3 and 4, as well as 5, is seen in the kidney, mostly in the glomerular basement membranes, distal tubule basement membranes, lungs, ears, and the eyes. And then alpha 6 can also be seen in the distal tubules and Bowman's capsule, and even in the epidermal basement membranes. And the Bowman's capsule and epidermal basement membranes also express alpha 5. So these 6 alpha chains, they kind of arrange themselves in 3 that form heterotrimers. Glomerular basement membrane is typically 3, 4, 5, 3, 4, 5. And in normal maturation, when we are early in development, it's at first alpha 112, 112. But when the glomerular basement membranes start to mature, they isotype to 345, 345. So that's what should normally happen. But in patients who have Alport syndrome, because they are missing either 3, 4, or 5, they don't assemble the 345 configuration properly. So they have an absence of that. And because of that, they retain the alpha 112 configuration. And so that is much weaker. It cannot withstand lifelong filtration pressures. And so that's why we see the lamellations in these ultrastructural examination of their basement membranes. So here's an ultrastructural example. So here is some subepithelial scalloping. You can see there's splitting of the basement membranes. And there's even some subendothelial scalloping. There's like this exaggerated outpouching. And then here, again, just to show the basement membrane multi-layering, you can see that it's all throughout the whole entire layer of the basement membrane. It's involving the lamina densa. And in some of the areas of the lamina lamellations, you can see these clear areas. They have this granular electron dense material that's sometimes called crumbs. And clinically, because they involve abnormal basement membranes of the kidney, you have glomerular basement membranes that are not filtering properly. So you're going to see hematuria, proteinuria, and hypertension. And then ears, the basement membranes of the ears and eyes are also abnormal. So you're going to have hearing defects and visual disturbances. Genetics-wise, majority seems to be X-linked, and that usually involves collagen alpha 5. Because it's X-linked, it predominantly affects males, and these patients typically have like the worst clinical presentation. So virtually all patients progress to end-stage renal disease, and 90% by the age of 40. Females, because they're XX, they can present with less severe presentation, and 12% do progress towards end-stage renal disease, and 30% by age 60. The remaining are autosomal forms. Autosomal recessive is the next most common, it's up to 15%. But the autosomal forms are typically 3 and 4, and they have a very variable, heterogeneous presentation. So some patients can just have asymptomatic hematuria, and some can present towards end-stage renal disease. It's really based on how bad the mutation is. So the differential diagnosis, just to go through some entities that can have Alport-like basement membrane changes. So the first one is pediatric donor glomerulopathy. So these are patients who are adults who get pediatric donor kidneys. And this pediatric donor glomerulopathy was actually coined by my mentor, Suzanne Malik Smith. She came up with that term. And what she found was that the basement membranes look lamellated like Alports. But unlike Alports, you can see that the splitting is mostly subepithelial, and you could also see some subendothelial. But the lamina densa is preserved. So that's one of the differentiating features. And the basement membranes can be variable. It's usually focal. Sometimes you can see severe. These patients who have pediatric donor kidneys, they do present with proteinuria with this entity, and it seems that patients who are receiving a kidney from a donor that's less than 5 years old, they will have this kind of change more often because I think the immature basement membrane is not fully mature, so maybe it's not capable of dealing as well to hyperfiltration injury. And then here is congenital nephrotic syndrome that can also have Alport-like changes. Diffuse mesangial sclerosis is one of them, and that has multiple syndromes associated with that. But the top 3 that's often seen is Dennis-Stresch syndrome and Fraser syndrome, which are both WT1 mutations, and then there's also Pearson syndrome, and they all involve nephrotic syndrome during early life. And then lastly, we have immune complex glomerulonephritis. Anything that has immune deposits involving the glomerular basement membranes, when those deposits resorb, it can look kind of Alport-like as well. You can see some of these deposits here. They look like they're partially resorbed, but you can see how like there's some lamellation. There's like a string of maybe the lamina densa still intact, but some of this looks like it was previously filled with immune deposits that probably cleared out. So then I'm going to go to another case, and this is a 70-year-old man. He's not young. He's actually he was biopsied because he had very low-grade proteinuria. And I think they were probably thinking that he might have something like maybe early membranous or hypertensive arterial nephrosclerosis type of thing. But what we saw in here is that the light microscopy looked normal. He had pretty essentially normal looking glomeruli, but the EM showed diffuse thinning of the glomerular basement membranes. He had like an average thickness of 220, and more than 50% were involved. And so based on that, it was diagnosed diffuse glomerular basement membrane thinning. And so just to talk about thin basement membranes, it's called, or we've been calling it benign familial hematuria in the past, or thin basement membrane nephropathy. But a lot of these cases seem to, well, not a lot, but some of these cases seem to be associated at least early in Alports. You can see diffuse thinning early in the disease process, especially if it's a heterozygous female carrier. So, some of these thin basement membrane cases that we think are benign are not always benign. So some of these patients can have Alport syndrome that do progress, but just present with diffuse thinning in the beginning. And so the question is there a pathogenic overlap in some of these cases? Can thin basement membrane actually represent a type 4 collagen disorder that is unrecognized? And some genetic studies have shown that about up to 50% of these cases do have a pathogenic or likely pathogenic variant of collagen 4 alpha 3 or 4. And they typically are heterozygotes. So based on this, it's been proposed by the Alport syndrome classification working group that thin basement membrane nephropathy should be included under a collagen 4 related kidney disease, because it's not as benign as I think we thought before. So the diagnosis of thin basement membrane nephropathy typically is generally accepted that more than 50% of the glomerular capillaries should be involved, should have diffuse thinning based on the age and sex. And the measurement of the GBMs are affected by several factors. The main three is the fixative and embedding compound, the method of measurement, and the lab criteria used for measuring what is considered normal thickness. So starting with the fixative and embedding compound. So I think one of the things that I think this was mentioned before is that glomerular basement membranes can appear artificially thin when it's reprocessed off of paraffin, deparaffinized formalin-fixed tissue, and this might be due to dehydration. So you can't diagnose thin basement membrane nephropathy off of paraffin tissue that's been reprocessed for yet. Another thing is that there are several studies that show that certain embedding material like spurs, low viscosity spurs embedding resin, tend to have thicker basement membrane measurements compared to other material like bestopol and methacrylate embedding material. And then the method of measurement, there is a lack of consensus on how to best measure. But the main two that seems to be use is the orthogonal intercept method and then the direct measurement method. And the orthogonal intercept method uses a grid that is superimposed on an electron micrograph. And the measurements are done at the points where the line from the grid intersects with the endothelial cytoplasm and the basement membrane that's right where the podocyte is. So these two arrows here, this arrow here and here, these are points where you can measure the basement membrane. And then using the calculations from off of these measurements, they do a mean harmonic thickness measurement or calculation using complicated equations. And that's where they get their number. And the advantage of this method is that it's truly random, and you're also able to include tangential sectioning, which you cannot do with the other. So, and it's very repeatable. You can actually get the same or similar measurements over and over again. The one that I think most labs use, though, are the direct measurement. So with the direct measurement, you're measuring from the side of the basement membrane, that is where the endothelium is, and then to the side where the podocyte plasma membrane is. And it's usually agreed that you should do multiple representative measurements over multiple capillaries, but there's not really a consensus on how many capillaries you should count, how many measurements you should do. But overall, I think most agree that it should be in the peripheral capillary loop. It should not be in the area that's where the mesangium, where there's a mesangial reflection. And it should not be a tangential section because that will have artificial thickening. So one method was from Dr. Malik Smith, actually. She used a method where you just take a pretty much a cross or a line and measure the 3 o'clock, the 12 o'clock, and the 9 o'clock areas for the measurements to get uniform measurements through each of the capillary loops. And then some individuals, they use at least 16 measurements in two glomeruli. And Doss et al. Actually did a paper on that, and they found that doing this was reproducible with the other method, but tends to have a little bit thicker glomerular basement membranes by 40%. And then after we do the measurements, you do an arithmetic mean, which doesn't require complicated equations like the other ones. So this is probably the most easiest method to use. And then lastly, you have the lab criteria that is used for normal GBM thickness. So also there is no consensus on what criteria they use for what is normal GBM thickness. The two that I've referenced here is the one from Columbia University. They measure it based on tissue that's fixed in 2.5% glutaraldehyde that's embedded in epoxy resin. And there's this 350 plus or minus 50 nanometers for males and 300 plus or minus 40 for adult females. And then Haas did a paper showing pretty much similar measurements. This was based on a 3% glutaraldehyde fixative with epoxy resin, and it's 330 plus or minus 50 for males and 305 plus or minus 45 for females. So it's not that big of a difference. And so based on what is considered normal, the lower limit of normal is defined as greater than 2 standard deviations below the mean value. So for the WHO, they use for practical purposes adults as 250 nanometers. The problem with that is that they're not differentiating between male or female sex. So that is the drawback for that number. Children, 180 nanometers. And then for Columbia University, they consider anything for males less than 250 as being thin, females less than 220 nanometers. And then for Haas's paper, 230 nanometers is the lower limit of normal for males and 215 for females. So there's a little bit of variation. So just to go through the differential for thin basement membrane nephropathy, IgA nephropathy can have some thinning in the basement membranes. It's typically segmental. 31% of these cases can have that, but it seems that in some studies, some of these patients can have a collagen IV mutation. So it's not always because it's an IgA nephropathy. It could also be that there is a collagen disorder there. And then other glomerulopathies like lupus nephritis, post-infectious GN, etc., even diabetic glomerular sclerosis, you can have focal segmental thinning of the basement membranes due to the injury and remodeling that occurs. And then lastly, thin GBMs. Sometimes we have patients who get a diagnosis of thin basement membrane nephropathy and they don't have a collagen IV mutation. So they found in one study that just got published recently that some of these patients actually have other mutations. So it could be that there is a mutation, not just involving collagen IV, but others that can cause thinning of the GBM. So anything that's nephrotic syndrome related, like nephrin, congenital K-cut has been implicated, other things. So there seems to be a broader genetic basis for thin basement membrane nephropathy. So just to follow up our patient, seems like this patient had a collagen IV alpha-3 autosomal dominant mutation after all. Because in the 70s, most patients don't even have suspected collagen IV mutation. They usually don't even do genetic testing at this age. So this was a little unexpected, but seems like he had a heterozygous mutation and just had a milder symptom. So, but it happens at all ages, so it's not just in young patients. And that's the end of my talk with this one.